Welcome to the Body and Beyond podcast with Alice and Gina.
A podcast sparking discussion on all things health, mindset, fitness, goals, and motivation.
We strive to help you to boost your confidence, to take the lead in your own life, to back yourself, and to step into your full potential. Body and Beyond is proudly sponsored by The Seed Cycle. The Seed Cycle is a beautiful female-founded Australian company. Seed cycling is a natural methodology that you can use to support your menstruation and your ovulation, and it can even be used to support your hormones through perimenopause and menopause. Use the code BODY and BEYOND at the Seed Cycle website www.theseedcycle.com.au. What are you saying? You're talented at? You got the talent of what?
I got the talent of a brick wall when it comes to music. But that's also kind of offensive to brick walls. So you can't have everything.
No, you can't. You can't be ridiculously good looking, a great physio, and have the talent, the musical talent.
I have no creative bone in my body. Like Sam, my 6-year-old, draws better than I do, I think.
I can believe that. Anyway, everybody, welcome to the Body and Beyond podcast with Alice and Gina. Today we have the wonderful physiotherapist, Rob Taylor. Hey, Rob.
How you going?
Welcome.
Nice to see you here.
Thank you for joining us. And what's our topic today, Rob? What would you like to take us through?
I think we decided to talk about injuries in weightlifting and sort of the signs of what brings on an injury, or discussing what actually can bring on an injury, and then also when to seek help.
Yes.
Other sort of thing we're going to talk about.
Yeah, awesome. And that's what we really wanted to stress for the listeners is when to seek professional guidance, whether that's from a coach or a physiotherapist, before the situation gets worse.
Yeah.
Yeah, cool.
Cool.
Great.
Take it away. What should we start with?
I think we start with some misconceptions amongst weightlifting and powerlifting communities, or people outside of those communities, because I think once you're in those communities, you see the realities of injuries, which are actually on par with pretty much all other non-contact sports. So if we look at the injury data for most sports, for non-contact sports, anything between 1 to 4 injuries per 1,000 hours of competition or training is standard, and both weightlifting and powerlifting fall within those categories. So a couple of systematic reviews from a couple of years ago, weightlifting was a little higher, sort of about 3.3 injuries per 1,000 hours, and powerlifting somewhere about 1.4 injuries per 1,000 hours, which is on par with your non-contact sports. For reference, contact sports, rugby, AFL, soccer, that sort of stuff, have an injury rate of about 10 per 1,000 hours. So that's pretty much on par. So that conception amongst the community that injuries in powerlifting, weightlifting are higher than normal is actually not true. And the reality is that it's pretty much on par with other non-contact sports. So take that as running or swimming or any sort of other cycling. About the same, basically. Yeah. So.
And just to clarify for the listeners, when you say weightlifting, you're talking about like Olympic lifting or gym training?
So Olympic lifting is probably the one with the most amount of research. So when we're talking about this, we are probably talking about Olympic lifting. Yeah. Powerlifting has some research, and CrossFit also has a growing body of evidence. General gym training, you can apply the same principles, but it's actually potentially less risky than the other types of sport.
Yeah. Less extreme, right?
Less extreme,
less vulnerable positions, ideally.
So ideally, yes. To be honest with you, there's not a lot of research on general gym training and injury rates, but you can apply the weightlifting and powerlifting and CrossFit type data to general gym training, and the data basically says it's no more risky than any other type of non-contact sport. Yeah.
And before we go any further, so what's your background in sport and how did you get into physiotherapy?
My background's long. I took up rowing at 13 and ended up in the state rowing program, and then at 18 went into sort of junior elite rowing. Got quite significantly injured at 19 and went into recovery for that. Gave up rowing, which is a whole nother story. And that piqued my interest in physio, because it was eventually a physio that actually got me better and got me back on track. And then concurrently, I played probably about 20 years of rugby, and then took up powerlifting at around 22, 23, and competed for about 10 or 15 years until I got a bit older and had kids, and then stopped doing everything, basically.
But not anymore. You're back into it.
Yeah, sort of.
And in the meantime, you had massive hip surgery.
Yeah, I've had a couple of hip surgeries, had a couple of knee surgeries, and a few other injuries along the way. But actually, to be honest with you, most of my injuries are actually traceable to rowing and rugby, and I've had very little significant injury from many years of lifting. A couple of shoulder issues over my time, but you could probably go as far to say they were self-inflicted with inappropriate training loads and trying to be a little bit keen to break records or break my own records.
And simply put, how would you say those injuries do stem back to rowing? Like,
my hip problems all stem back to rowing.
Is this from repetitive?
Young, probably been too young to go into sweep, which is single oar, and then just the high repetitive nature of rowing. Also, it's going to sound funny because I'm 6'3", but I am too short to be a professional rower. So
not lanky enough, like not long.
Yeah, just shorter than everybody else. So to achieve the reach that is expected for a normal rower who's about 6'6" to 6'8",
Wow.
I had to overreach, which is probably what led to my serious back injury and my
Wow.
Yeah.
So,
and is that having to too much flexion?
Essentially, you're having to hyperflex.
And repetitively.
Which in and of itself is not an issue, except when you do it for 7-8 years at a
high level, right?
Yeah, I mean, I rode it at Junior Olympics, Junior Australian sort of level. Never made Sydney team because of an injury, and I don't think I was probably good enough. But at that competitive level, yeah. So especially at a young age, I got picked up, started sweep training at 14, which is these days considered too young.
Yeah.
So, professionally, I have an undergraduate degree in medical science, a couple of postgraduate qualifications in biomechanics and exercise physiology, masters in physio. I've just finished my sports titling masters as well.
Your sports what?
Sports titling, which is a sort of an advanced physio position.
Yeah, and that's the one you've been working on for the last 2 years?
Through 4 years. And then I'm probably going to start some strength and conditioning qualifications next. So currently work for the Canberra Capitals as their head physio, full-time in private practice, and have previously worked at the RAS and a few other places as well.
Yeah. And for those who don't know, the Canberra Capitals are the basketball team.
The professional women's basketball team.
Yeah.
So worked in rugby for many years as well, but not as interested in rugby these days. Kind of stepped away from it.
Yeah.
So that's me.
Oh. It's a long background.
It's a long background. It's a lot of years of study.
You're not even that old, are you? Really?
I'm old enough. I'm feeling old these days.
Yeah. Knowledge, though.
Yes. So back to injuries.
Yeah.
Your classic injuries for most people when they think about weightlifting and powerlifting are actually kind of in line with what the research says, which is that the most common is shoulders, knees, and lower backs. Which you guys would probably agree with. Weightlifting has a high incidence of knee injuries, actually, surprisingly. Powerlifting has a higher rate of shoulder injuries, and back injuries are about even across both.
And more specifically, so let's look at powerlifting. Which movements have you noticed?
Interesting you say that.
Yeah.
Shoulder. Well, the data actually says that there's no increase of overall injury rate across all three lifts. So that myth that deadlifts are dangerous, deadlifts cause injury, actually doesn't play out across the population. Doesn't say that's not necessarily true for the individual, but that's more down to loading and technique and other things. When it comes to shoulder, bench press is usually the accepted. Bench press data is an interesting data. Realistically, the high amount of pec tendon injuries and things like that in male powerlifting are actually mostly associated with steroid use. And general shoulder issues are actually not highly associated with bench pressing. They're universal across the program. So, hard to say. But it doesn't seem that any of the three main compound lifts place at any higher risk for injury than the other ones. And then weightlifting, there is a higher incidence in snatch compared to clean and jerk.
Of this shoulder.
Of overall.
Of overall.
Yeah. So, but it's not a massive difference. I can't remember the exact the exact amount, but there is a slightly higher injury risk in snatch compared to clean jerk, but that makes sense. It's a more difficult movement.
Yeah. And this kind of research, is this predominantly looking at athletes, or are we looking at some, like, no, it's not general population learning,
Well, some of it is.
Yeah. Okay.
So that article I was talking about before is a systematic review, which pulls research from multiple articles.
Yeah. Cool.
So you basically, the way to get an idea of what research is really saying is to pull data from multiple
studies, multiple countries, multiple
exactly.
researchers.
So yes, some of the Olympic weightlifting in particular data is from professional athletes, but then again, some of the data is from more general data, including a lot of the CrossFit data. It's kind of handy because it does seem to be across population levels rather than specifically high level athletes. But yeah, you can roughly draw some conclusions though. Athletes get similar injuries to general. Yeah, maybe different rates.
That injury is people are more prone to injury when they're at the beginner level, or more at an athletic or athlete level?
Probably different injuries would probably be the way to put it. Yeah. When you've got a lower base, lower condition level, lower sort of adaptation to load, you're probably going to get more niggle type injuries, a lot more of those sort of tendon type issues as your body adjusts to load, basically. And they're also the type of people who tend to get those really acute, like back or neck type issues.
Yeah.
Just from the lack of familiarity with the movement, I guess, is probably the most common.
Or you also say like postural issues, then loading, like they've got these underlying everyday life postural issues, then they're loading. Incorrectly.
Yes.
Well, not, incorrectly for that point in time.
Yes. Yeah. So their work does impact how they can then approach the gym. But that's where good coaching comes in, where they appreciate their work and what they do. And good coaching really is about that idea of getting that person to learn how to do things and how to, to adjust the load rather than throwing them off the deep end in the first session.
And being selective with the tool you're using as well. Like, for example, if someone has got postural or shoulder issues, you do not need to use a barbell. Like some people are attached to the tool that they're using for their exercise. So.
Yeah, so if you're a 40-year-old person who's never been to the gym and your first session you're learning how to do heavy deadlifts, that's probably not going to go. But if
whereas you're learning the movement of hinging and deadlifting in general.
Yes, correct.
Very different.
Appropriate for what your level is at.
Exactly.
More athletic populations, they do get a lot of the tendon pathologies, but they're much more traceable to the changes in load. So that could be a break from training, that could be a new training program, that could be peaking into competition and then back into training, all those sorts of things. They're usually much more pinpointable, and that's what I do a lot with my athletes is you can pretty much pinpoint where the error was, basically. There's a good example from my last season with the Caps. We had a player who came in, had 2 sets of quarantines because of COVID in a short period of time, and couldn't do the load because she was stuck in a hotel for 2 weeks, twice in about 6 weeks' time. And she got a bone stress because she was unable to load, went into what we hoped was low enough load levels for her to not get an injury. But even then, it was an overestimation of what her capacity would be because she had come off a full season, so we didn't expect her to be that low. And so athletes, but we knew exactly what had happened to cause that injury. That makes sense. Yeah.
And what was the example? Like,
what do you mean?
What was the injury? Like, what happened?
So it's a bone stress, a foot stress fracture.
From impact without?
Just from the general loading of basketball.
Of basketball, okay, gotcha.
Yeah, so running and jumping.
Not necessarily an acute.
No. So bone stress injuries are not an acute injury. That's a fracture.
Gotcha.
Bone stress is where, so all tissue adapts to load. Yep. So you do weight training, your muscles hypertrophy, your tendons hypertrophy, your bone density increases, etc., etc. Okay. All tissues adapts to load, but how fast that tissue adapts to load depends on the tissue type and the loading. So if you've got a period of deconditioning and you go back to high loading, so like a professional basketball scene, even with modified load, then there's enough force that the bone can't keep up with the loading and you start to get degeneration bone, which is a bone stress fracture.
Yeah. And what was this isolation period or this?
COVID. It was two-week blocks from coming back into the country and then coming I think it was a COVID exposure, not an actual.
So we're talking a 2-week block, or you said two weeks? So a month of low.
So she went, I think it was in 6 weeks, she had 2-week blocks of
wow, that's quite rapid. I guess I'm just trying to understand the reduction in exposure, and then
So the research is pretty clear on that, actually, that even a reduction between 7 to 10 days is enough to cause injury. So if you get a week where you're off sick, your load needs to be adapted for the following 2 weeks to make sure that you're back to work, basically. So 7 to 10 days is enough change in load to cause injury. Anything under 4 days is usually generally accepted as not. 4 to 7 is a bit grey, if that makes sense. So not only off that week, that 7 to 10 day change, and obviously the longer the time off, the higher the risk. When you track that change, you can track which type of injury they're going to get at which point pretty accurately from that data. So if you say week 2, so when they restart training would be day 0. Week 2, you see the muscle tears. Week 3 to 4 is when you start to see bone stresses, and week 4 to 8 is roughly when you start to see the tendon type pathologies coming out. So not only do we know how long it takes for those injuries to rise, you can also pretty much accurately track if they're going to get an injury, what injury it's going to be at each stage, basically. So that's where you're monitoring load. So when we're talking about an actual athletic population, we're monitoring not only load in terms of total minutes, we're monitoring with the basketball players, we're monitoring total jump numbers, we're monitoring total load in the gym, what their recovery is, how they're actually physically feeling, all these sorts of things to try and get the best handle on how much load we can give to our athletes without breaking them. So it's a bit harder in the general population to do that. But you can roughly track load with how much weight you're moving and how much change in intensity you're having in session.
So what would your input be for general population doing strength training in the gym?
That's a good question. The accepted load variance, so you've got 2 types of load.
Without getting too technical, by the way.
Yeah.
You're like, well.
You've got 2 types of load you've got to monitor. You've got the acute load, which is your week's worth of load, and you've got your chronic load. Now, your chronic load varies depending on the sport. We track 4 weeks worth of load total in the basketball players, and the rugby players is roughly around the same sort of load. But if you're talking about, say, running and swimming, they tend to track over the course of like 8 to 12 weeks as their chronic load. So your chronic load can't increase. The injury risk is significantly higher once your chronic load is over 10%. So if your load changes are over 10% and sustained over 4 weeks, or higher than 10%, then your injury risk is significantly higher.
So is that weekly 10% over 4 weeks?
Yes.
Yes.
Yeah. Okay. If you're tracking your general population, so that's in an athletic population, they already have an accepted load base.
Yes, exactly.
There isn't hard data on that, but I think you're playing with fire over about 7% in the general population.
Okay.
Yeah.
And also, I'd love to know your input as well on like subjective experience, like their actual like feeling, like giving validity to how it's feeling.
Yeah, so then you're back into RPE, which is rate of perceived exertion. Basically, if you're sustaining over, I think it's 7.5 or 8.5, I can't remember which one it is. I have to look it up. But if your sessions are going over that 7.5 and sustaining, that's when you start to get that increasing risk. I'd have to look that one up. I can't remember.
Sure.
So that 7 to 10% change in load is the sort of 10% for your athletes, but that's up for debate as well.
Yeah, because is that a 10% increase from their genuine, best efforts and general?
No, that's total volume.
Yeah.
So you can track it in terms of total volume.
Okay, so we're talking volume. So it's a 10% increase in volume.
Or you can track it in terms of intensity. So in terms of your weight training, that you've got to factor in rep loads.
Yeah.
So if you added increased rep load but kept the weight the same, you've increased by a certain amount of percentage. But if you change a rep range, increase the rep range, and increase the weight, you have changed it twice.
Yeah.
So you've got to factor that 10% and get both of those under that value, if that makes sense. They're not 10% for one, 10% for another. They're counted together. So rep range increases and weight increases are both contributing to that 10% total number.
Yeah.
That's where it gets difficult. Because changing exercises, or how do you if I change this exercise and do this exercise, how does that factor compared to the previous exercise, et cetera? Generally, your compounds are going to be harder than your isolation, but that's generalized rule. It's easier in running because you can track length of time, distance covered, pace, etc., etc. Gym training is more difficult.
There's a lot of variables there.
Yeah.
There's a lot of variables.
A lot of variables,
Yeah. But if you're working under somewhere around 7 to 8%, you should be relatively safe. Yeah. Bearing in mind that breaks from training are the biggest risk factor for injury. Yeah. So you get sick, you get work, get stuck at work, you know, an injury or another type of injury, or, you know, whatever reason that you change your program, that's where you're potentially going to run into problems. Yeah.
And so moving into when someone does start to notice or feel something's not quite right, or maybe they do have a more serious niggle or injury, what's your viewpoint around when to seek help or when to reach out to a professional?
So I think one of the other big myths with lifting weights is that all injuries are going to be those big acute injuries. I lifted something went bang, I was in immediate pain. It's actually quite low numbers.
Yeah.
So probably the accepted number in athletes is around 20% of injuries in weightlifting, powerlifting will be acute injuries. And then actually means 80% as chronic injuries. I have no idea how it started, but now I have shoulder pain. Yeah.
That's usually.
And this is probably.
But I've definitely had bang ones.
Yes.
Yeah. I've had 2 bang ones.
Yeah, I had one great bang one where I tore a ligament in my hip.
One great bang.
Yeah. Trying to do overweight deadlifts, being really stupid and younger, and trying to increase my deadlift weight and doing block pulls that were overweight, and that instant bang. And, the person sitting next to me was like, "What the hell was that?" Well, that was my butt muscle. Yeah.
That was your what?
My hip. My butt muscle. Yeah.
Right.
So, but that was literally my only injury, my only bang injury, I think, in 20 odd years of lifting weights. Most of the time it is literally, I noticed, you notice something gets sore and it increases in that pain, and that disability increases over time. Yeah. So most of your injuries are going to be that. And that kind of gives the game away as to what it's going to be too in most situations.
Yeah.
In most situations, that type of insidious onset is going to be most likely some sort of tendon pathology.
Yeah.
And the reason for that in weightlifting and powerlifting is everything hypertrophies, so everything gets stronger, I guess is probably the way to describe what hypertrophy is. But tendons can only adapt to so much load, and you can't make them adapt any faster.
It takes time.
Yeah, they're an unusual tissue type. They're a connective tissue type. They're not a muscle. They don't grow in the same way that a muscle adapts to load. And they often don't. So if you do an exercise, you get DOMS, you feel the muscle soreness, you know you've done something. Well, tendons don't really feel pain in the same manner. They experience pain differently. They're not avascular. They do have a blood supply, but they're kind of altered. Their response to injury is different to normal tissue, to other tissue types. I should say normal to other tissue types. So the way they behave and the way they experience pain is different to how other tissue types experience pain. So often it's not you're brewing a tendon issue before you even know you're brewing a tendon issue. That makes sense.
Yeah, and this is why I really wanted to get you on as well. It's for the listeners to see that sometimes, like, really checking in and listening to your body. If you can feel something starting to be not quite right, or like you mentioned, something starting to brew.
Yep.
Then the earlier you can reach out to a professional, the better.
Yeah. So in my mind, because they will happen, niggles will happen, and you will have sessions where you're like just that randomly hurt, and I've got no idea what the hell happened. We've all been there. If you're getting consistency in an issue, so say every time I overhead press, my shoulder hurts, but then I can do all of my other gym exercises normally. But if you're getting consistency and it's over at least sort of sustained over sort of 3 sessions, then it's really worth time to check in and actually have that looked at. The sooner you head something off, the sooner you'll be back, basically. Yeah. So data place something along the lines of if a tendon issue is recognised within 2 weeks of symptoms, the loss of time will be up to around 4 weeks. If a tendon issue is ignored for greater than 6 weeks, the loss of time is usually greater than 12 weeks. So that loss of time does not mean out of the gym. That would mean modified training. But the modifications to training would be much more sustained even with a shorter period of time of ignoring it compared to jumping on it relatively quickly. Yeah.
And what are the most common tendon issues that you come across?
Shoulder's probably number one.
Yeah.
Yeah. So rotator cuff tendon issues, which most people would have heard of. We're not talking about tears or injuries like actual tears. They're actually relatively uncommon in the young population in gym training. And to be honest with you, a lot of the current research is kind of pointing out that over the age of 40, that rotator cuff tears are actually pretty standard across the population. So at around 40, about 30% of the population will have a rotator cuff tear of some description on an MRI. 30% of the population are walking around with that, but 30% of 40-year-olds are not walking around with shoulder pain. So that's an entirely another conversation about when is imaging relevant. By the age of 60, it's around 50-60% of people are walking around with rotator cuff tear. So they're really common. And that does not mean that 60-year-olds are walking around with shoulder pain. In fact, the vast majority are not.
Especially if they're not really doing anything or training.
But not even. Like they're more common in sporting populations or previously sporting populations. So well, the rotator cuff tears are also linked heavily to work as well. So physical work versus desk work as well. But rotator cuff would be the number one. And that would be your classic one. There's 4 of them. The most classic would be supraspinatus, which is the colour one on top. Its job is to keep the arm ball basically in the socket, pulling it upwards. Probably the best way to describe that. So any sort of overhead movement, bench press can be provocative, but any sort of overhead movement's the classic sort of position you're going to feel better.
I've had a Dutch shoulder for like probably 2 years now. So this is all just
rings a bell.
Let's not go there.
So I counter that with tendinopathy is not the whole picture. Often it's not, with the way a lot of modern lifestyle is. We're talking about posture and desk work, and how a lot of people are relatively deconditioned from their work lifestyle. A lot of the tendon pain that people feel in shoulders is what there's a few people out there would term as what's called rotator cuff overload. Best way to describe that is everything at the front is kind of tight and a bit dominant over what's at the back and at the shoulder, basically. And the rotator cuff's overworking because of the way the person feels. So you're people with the stiff thoracic spines who look a bit rounded, who don't have great shoulder blade control, aren't great with a row. Those sort of people, they're the ones who are going to get that overload, and they're going to get a tendinopathy based on the problem being the way that they're structured, I guess, if that makes sense.
And when you say the way they're built, do you mean nature or nurture?
I mean,
we're talking
nurture, not nature. We're talking desk life.
We're talking this has happened over years. This isn't, they weren't born this way.
No,
a baby comes out and it's like.
And you guys would see it all the time, right? Like you see people coming, desk workers, and they're relatively good with anterior type exercises, but they stick them on a row and they're not great. Or their control is not great, or the weight they can handle is not great. And they lack thoracic mobility, they lack the ability to get their arms overhead easily, those sort of things. There's something to be said about modern lifestyle on that problem.
But it is possible to start to reverse it, or to start. You
can reverse it. It's completely reversible.
Not all
get there
is over.
You can get rid of it. So there are a few structural ones out there, but they would almost always know they have that problem. I think me and you share a patient at the moment. Well, you share the client, a patient, who we know there's some structural issues that we are never going to reverse, but they're also aware of that too, and we just work within their limitations. You don't push them into things that might be provocative. But we know their limitations. But that's a unique case, and the vast majority of people, it's completely reversible. And in fact, gym training is probably the best thing they could do with themselves. Strength training, upper body strength training, 100%. And I encourage a lot of my desk working population to take up some form of training, to help with their problems. So,
other tendons?
Other tendons?
Hammy tendons?
No, not so much. They're more usually related to sprinting, AFL types of issues. Patella tendons is a possibility from squat weight, heavy squat loads. But again, not massively common. I guess that'd be more common in your weightlifting communities. But that's more commonly associated with jumping. So people jumpers knees, so basketball, volleyball types of things. I suppose another good one would be tennis elbow. So elbow, so lateral extensor tendinopathy. That's a gripping type one. That's an interesting conversation. that's a hard one because personally, I feel a lot of that's often driven by crappy shoulder mechanics.
Oh, yeah.
Yeah, they have to overgrip or overwork the elbow to compensate for the poorer, more proximal chain.
Mm-hmm.
Yeah. So that's not a universal truth, though. That is not universal.
No.
But
and you can see similar things happen with the lower body as well. As,
yeah. And I guess the most classic tendinopathy is Achilles tendinopathy. But again, that's very much more in the realms of running and jumping sports, and not an issue that you'd see in a lot of weight training. I suppose if you're doing more functional training and CrossFit type stuff with more jumping, you will start to see that more often. Yeah. So, but if you're doing more traditional powerlifting, you're not going to see that very often. Yeah.
It's pretty powerful. Hey, sometimes people have an injury pop up that really there's something happening like biomechanically elsewhere in the body that's then flowing through.
And realistically, like a good therapist is what is going to be able to work and not only treat the injury, but also work with you on things that have contributed to that.
Look at the whole body and how it's moving and go, hang on, what's really happening here? Yeah.
So my advice when it comes to therapists, because I hate to say it even about my own profession, there are good therapists and there are bad therapists, is you really want to be working with somebody who's going to help you understand what your injury is and how you're going to manage it, but also help keep you in the gym and training. And if that does require modification to some exercises, then so be it. I definitely do that myself. I would say, right, we know that this exercise is really provocative and it's setting our symptoms off greater than we really want to be, so we're going to have to move away from that exercise for a period of time. But there should be modifications to that exercise or movement that you can do to keep you training, and there'll be whole sections of body that can be continued to be trained as normal without any risk, basically. So if you've got a therapist that has said, well, don't go to the gym for 4 weeks, you've gone wrong. There's always modifications that can be made to keep people going.
And like we were saying earlier, if someone's injured their knee or injured their shoulder, there's still for health and, their mental health as well. There's so many things you can be doing.
From my point of view, we look at it as a load problem, right? If you take all the load away, you're setting yourself up for other problems. What's the biggest risk for an injury is having a recent injury. And that's usually to a different area of the body. So you don't tend to re-injure the same area. You might say pull a hamstring playing footy, but then 4 weeks later you tear the other hamstring. So the biggest risk factor for an injury is a recent previous injury. So if we can keep you loaded to as much load as we can safely allow you to do, that is the ideal situation. And dropping all your load out, all your training out is generally a bad idea. It's generally setting you up for another type of problem, basically. So that is half my job, is trying to find ways to keep people going. The other thing I'd have to say about tendinopathies, and this is going to challenge a lot of people's views, is when it comes to pain is not a good guide for tendons. It's not, and I shouldn't say not a good guide, it's an interesting guide. So people have in their head that all pain is bad, and actually that is not how we look at tendinopathies. We look at tendinopathies as, right, okay, there's a certain level of pain that we find unacceptable, and a certain length of time that we find that unacceptable. But actually, so what I tell my patients, if you're my patient with a shoulder tendon problem, I would say, right, we want to keep it under somewhere between 3 or 4 out of 10 at all times. And that includes post-training. And we want to see that that pain is settling within 24 hours of a session. And we call that a stable tendinopathy. If you're sustaining pain over 3 or 4 out of 10 post-training, and in particular if it's sustaining over 24 hours, we call that unstable. So there's too much load, basically. But tendons are weird. Too much load, they get worse. No load, they don't heal. That's a bit simplistic, but for where we're at, that's pretty much how you should look at them. So they're kind of like the Goldilocks of injury, so you've got to find the right
the right temperature.
The right temperature, exactly,
Tendon issues? You're saying your hammy?
I mean, I've torn my hamstring and I've done my... I actually can't remember whether it was the top. I don't actually know if it was the top of my rec fem or the hip flexor. Basically, it was a pop, though.
Yeah, okay.
And it was at the bottom of a very heavy squat, and I just bounced.
Probably a rec fem.
Yeah, I didn't hold tight, and I just bounced out the top. And as soon as I hit that momentum back up, it just Yeah.
Which is your normal situation for acute injuries is heavy load. Yeah. So normally your acute injuries are going to be under a heavier load. But there's something to be said for intra session fatigue as well. Often as not, those injuries happen when you're in a fatigue state, which I'm sure you've talked about in the past, is that if you're, had a shitty day, you're tired, work's absolutely at you, you're mentally not in the game, then that is not the session to be going heavy, because fatigue plays a role in that sort of situation. Yeah, and that's not just physical fatigue, that's also mental.
Mental fatigue and being present with what you're doing. Yeah.
Whereas if you had, 9 hours sleep and you're winning in the day, then that's the day to go heavy, right?
Oh, I had years of tendonitis in my hips, actually.
So tendonitis is the old term.
Oh.
Yeah. So now we've moved to tendinopathy.
Tendinopathy.
Yeah. Or tendinosis.
Belly dancer. Yeah.
Or tendinosis, as it's sometimes called. Why do we play semantics with the names? We play semantics with the names because tendonitis implies inflammation, and tendons aren't truly inflammatory. There's a whole classification system developed by a woman in Melbourne and a guy who used to be the head of the Australian AIS. Awesome research, well worth a read. A little technical, but well worth a read. Tendons go through 3 stages of injury, and what you actually tend to see is a chronic tendon issue that has an acute flare-up. So we call that reactive on chronic tendinopathy. So that you get a tendon that's already looked or has been cranky for many years, but then you do something that pisses it off and it goes acutely sore. Yeah. And that's actually what we tend to see as physios in the practices. It's always been there, like you were saying, I had shoulder pain on and off for 2 years, and it's always been relatively low level and manageable. It hasn't stopped you doing anything, but then you do something out of the ordinary or heavy, and all of a sudden you're like, now it's cranky. Now it's stopping me from doing it. Yeah. So that's how tendinopathies roll. So tendonitis is the old term. Tendonitis implies inflammation. Yeah, and tendinopathy or tendinosis is the
Yeah, cool.
Yeah, but they are the same thing.
Yeah.
So if somebody says to you they've got tendonitis, it's the same as tendonitis.
Yeah.
So we just health professionals like to play semantics with words.
No, it's good.
Yeah.
And it makes sense, right?
Yeah. But they are the same thing.
Yeah.
So a lot of doctors will call it tendonitis because that's what they learned. 20, 30, 40 years ago.
I was going to say a while ago.
Yeah. So, and I'm not blaming doctors for that one, but a lot of GPs will still call it tendonitis, but it's the same principle.
Yeah. What about you, Gina?
I was just thinking when you were saying that my hammy tendon felt like it flared up.
You've had hamstring tendinopathy,
which I have had in the past. Yeah.
I can say I've treated you for hamstring tendinopathy in the past. So
I've worked with you on that. Yeah. And that was probably just from squatting a little bit heavier. I probably need to think more about it.
Wasn't that you going back into some Olympic lifting?
Back in the day?
Yeah, no, when it flared up a couple of years ago, it was going back into some Olympic
probably, and more lifting again. Yeah.
I've had subscap in both. So subscap's another rotator cuff tendon. It's at the front of your shoulder more than the other ones. And I got that from being really silly with my bench press program and trying to break my records.
Too quickly.
All my own.
Without patience.
I should have known better. But I was like 25.
We've all done it once.
You do it once. We all do it once. And then you go, okay, that was a stupid idea. Not doing that again.
It's humbling for sure.
You learn more from your mistakes, right?
I was going to say it's an important part of learning, and it's actually a really good frame. Dave probably taught me as well, but like actually letting people know that when you start training, like there's going to be niggles that come. I like to frame that with clients when they do start exercising for the first time. Like you're going to start to get niggles at some stage, and that's completely normal. And that's having the right person
to deal with those
on their team. Like we always prescribe having a really good physio.
So the last point I think I'd like to make about tendons is we generally start with an isometric type loading exercise, and you've seen me do this with you in the past. Is basically, if you think of a bicep, concentric is the upper part, eccentric is the lowering, and isometric is essentially a flex contraction. And we use those for the first 7 to 14 days, basically with all tendinopathies, unless it's further along and we can push the load heavier. if for general population, if they walk in with a tendinopathy, it's generally getting to the point where it's uncontrolled. It's starting to get a little unstable. It's starting to do things we don't want it to do, because that's where usually people come in. They don't come in when it's just starting to be a problem. So we use isometrics as a basically to lower pain. So we want to get it under control, get it back to those sort of general rules of sort of 3 or 4 out of 10 and under pain-wise and settling within 24 hours. And if we can achieve that quickly, we can then start to reload the tendon and increase the load relatively quickly. So if you are seeing a therapist, they generally will use isometric exercises with you. Not always. It is really dependent on the individual and where they're at, basically. So back to one of my CAPS girls last year started getting patellar tendinopathy. We had her loading heavy from day one because we could. We never really used the isometrics with her because it wasn't necessary. But I said, but the state where most average people come in, it's getting towards unstable. So we really want to try and get pain under control as quickly as possible so we can start to reload as quickly as possible. Yeah. So the last point I will make about tendinopathies is
this is like the
last point. And it's a really important point, is that once you're out of pain with a tendinopathy, that tendon is not healed. You do not see true tendon healing for a significant amount of time after pain has stopped. So whenever I finish seeing a tendon pathology person, I will always set them up with a program that's going to last somewhere between 3 to 6 months. So you're trying to get as much change in that tendon as you can possibly get. And healing in tendinopathies is sustained over a very long period of time, and it is definitely not all done by the time the pain is gone. So if you get better from a tendinopathy, you should continue working on it for some period of time.
And sorry, is tendinopathy normally brought on by loading or
changes in load?
Changes in load, yeah.
So it doesn't have that capacity, as we were saying earlier, it doesn't have that capacity has a capacity to cope with a certain amount of load, and you can't really change that, if that makes sense. Yeah. So they will only hypertrophy as much as they will. And so drastic changes in load is what things are done. That's back to that. Changes in 10%. Yeah. And sustained sort of changes is where they come from. Yeah. So you're thinking about yourself?
Reflecting and thinking, never mind.
Nice.
Having some reflection.
I'll just sit in the corner.
I was just thinking about that time, I think I was telling you about when I did my Bulgarians.
And I'm like, that didn't pay for that.
I'm still paying for it today. So that was a bad choice.
Randomly
felt really good at the time. And then
randomly added in a pile of Bulgarians and do a program.
So I went back to Bulgarians, and they were barbells, so they were heavy. I think I was doing 65, 70 kilos.
Yeah.
But I hadn't done barbell Bulgarians in like probably 6 months. Like I was using dumbbells for a long time. So I was just loading it up thinking, damn, I'm still really strong with this. And then
and she's strong. So
like it was fine. But then I woke up the next day, and now I still have like my adductors are still like I can't do deficit lunging or anything right now. So it's weird. I don't know if that's what it is, but it basically feels like I have constant DOMs. Like constant DOMs. Like if I just like clench pull my legs in now, I can feel it.
Adductor squeeze. The test is called adductor squeeze. Put your hand between your knees and squeeze.
It feels like constant DOMs in a way, I guess. Like
that's an acute overload, right? Yeah. That's what we call reactive.
Bust me.
I can give you some advice on it. But I said that is your that's a relatively short turnaround, if that makes sense. It's usually over a more sustained period. Particularly those stops in load. That's the killer. Kids got sick, I got sick, I went away for 2 weeks with work, and then I went straight back into my gym program exactly as I was doing before, not respecting the 2 weeks of change load is usually what we see. Particularly with COVID and stuff like that, right? So last couple of years, people have been, I got stuck in quarantine, I didn't do any exercise for 2 weeks. And then I went straight back to my program because I was frothing at the mouth to do something, and they get those tendon issues. So I've seen a lot of that last couple of years.
So moral of the story is
if you're coming back from a break, your first week or two, you need to discuss with whoever's writing your programs that you need to change the load down and just rebuild over a couple of weeks until you're back to normal.
Lose the ego. It's okay to pull back a little
100%.
bit. Like don't stress about being behind a little bit or being a little bit lighter or
as you get older, as some of us in this room are getting, you realise it's a game of staying in the game, not a game of who's the best.
Yeah. And it's about that constant, as we keep saying, it's about that constant effort over time. That's what really matters. Not one event, the one trick pony. Yeah.
Yeah.
Awesome. Thanks so much for joining us, Rob. That was awesome.
Cool.
Lots to learn.
Thank you. Yeah.
Cool. We will tag you in the show notes.
Yep.
And you're practicing out of which facility in Canberra at the moment?
So I'm working at a place called Sports Care, and I'm working out of Barton and Bruce.
Yeah, Sports Care, Barton and Bruce.
Yep.
For all of our Canberra listeners.
Yeah.
And both Gina and I have both worked with Rob, so
yeah.
Which has done amazing things for us both.
Yes.
Only one of us in this room has a dodgy toe.
Yes, I'm sure most people would have heard me complain about my toes.
My injury list is
extensive.
Yeah. So when people go, how do you know about these injuries? It's like, well, because I probably had it.
Yeah.
Totally.
Yeah. Yeah, the little known secret about physios is that usually we are the most busted people in the room.
Yeah.
And the reason we're so good at injuries is because we've had them.
Yes.
Yeah.
Which is pretty powerful as well, having that experience, right? And being able to know what it feels like, have empathy, like genuine empathy, like be like, I'm sorry, I know what this feels like. I feel for you.
Yeah. Cool.
Great. Thank you. That was really good. Good chat. Yeah. Well, thank you everyone for tuning in, and we will chat with you guys in our next episode. But like always, if you enjoyed today's podcast, take a screenshot and share it with your friends. See you later.
Thanks, guys.
Thanks, Rob.
The Body and Beyond podcast is for information purposes only. This podcast does not constitute advice or services, and the statements and views of the hosts and guests are not medical advice. The information provided should not be used for treatment or diagnosis purposes. Please discuss any information from this podcast with your healthcare professional before making any changes to your lifestyle.